Hey everyone, Puneet here. Welcome back to North the Patient podcast, conversations on health beyond care. If you think back to the early days of viral content on YouTube, you might recall a 2011 video called 23 and a half hours that talked about exercise, the single best thing you can do for your health, through a catchy whiteboard drawing video, well before that became a thing. That video garnered over 6 million views and was one of the most watched public health videos of its time. This was the brainchild of Doc Mike Evans, who went on to build a med school for the public on YouTube with over 30 million students. What you might not know is that Doc Mike Evans spent the last 8 years working at Apple in Cupertino on special projects on their health team, designing and running experiments on how to improve the life and health of their over 1 billion users around the world. Doc Mike Evans is now on a gap year, and I'm honored to say that North the Patient is one of the first places where he's gotten a chance to discuss his career and his thoughts on the future of healthcare. In this episode, we unpack the storied career and the incredible range of experiences he's had, from working with Mother Teresa in Calcutta long before he was in medicine, to being a doctor at the Sochi Olympics in 2014, to founding a health media lab and a film company. He's really embodied the idea of working at the intersection of many different disciplines to advance healthcare forward. The links to the full episode can be found in the comments below. North the Patient is on Spotify, Apple Podcasts, YouTube, and Substack. Make sure to subscribe on Substack and follow along. As always, I welcome comments and ideas and suggestions for future guests. Without further ado, here is episode 10 with Dr. Mike Evans. Dr. Mike Evans, welcome to the podcast. It's an honor to have you here.
Thanks for having me.
How are you doing today?
Good. I'm in sunny California. We live in Los Gatos, sort of in between Palo Alto and Santa Cruz, and it's a nice place to live, and the weather's beautiful during the day and cool at night. So and no bugs. So it's great. Yeah.
A little bit different from Toronto, right?
Yeah. A little bit different than Toronto for sure. But we miss Toronto so much too. It's a little bit more Pleasantville here, so we miss the downtown Toronto for sure. But yeah, it's all apples and oranges.
Absolutely. So, this show is all about diving deep into conversations with creative and unconventional leaders and asking what the future of healthcare might look like if we use our imagination. And you, Mike, have such a fitting and remarkable journey. Just to highlight a few things for the listeners, you've been and are an academic family physician at the University of Toronto. You started a highly successful online public health campaign with your iconic whiteboard health videos on YouTube. And the last that I saw, you're north of 6-7 million views in some of them. You've served as a technology executive at Apple. Numerous healthcare startups in Silicon Valley have had your benefit of your expertise. And I know this is just the tip of the iceberg. So I'm really excited to unpack your journey and your thinking today, to get your insights on healthcare and where it might be headed. And I know that's going to be hugely invaluable to so many of our listeners, and because you offer such a unique vantage point. So maybe let's start right at the beginning. Tell us a little bit about Mike before medicine.
Yeah. So I was a English lit major in America. Puneet, all these high school students are like groomed from grade 6 to go to some Ivy League school. And I was telling some kid the other day that when I went to university, my two best friends, one went to Amsterdam for a year to run a bar, and the other one went to McGill. The guy at McGill got us an apartment, and they pulled up September, and I threw my hockey bag in the back, and my dad said, "What are you doing?" I go, "Oh, I'm going to university." He goes, "What university?" I go, "McGill." And so I picked English literature because I had a great English lit teacher, and I didn't even know there was a thing called residence. So I did a degree in English literature, and then I took what my kids call 5 gap years. So whatever, it sort of backfired on me now, because whenever I ask them what they want to do with their lives, they tell me to screw off. But so I was selected out to the national rugby team. I was sort of a jack of all trades athlete, not really good at one thing, but I was a construction worker out there. Then I worked in the high Arctic, like on an ice island just south of the North Pole, and made a pantload of money. Yeah. And then
how long did you do that for?
Just like 4 or 5 months, just living on an island. It actually breaks up So we were living in huts on skis and yeah, negative 60 every day and like a half hour sunlight at the
Oh my
beginning and
gosh.
24 hours at the end. So crazy. And then I made a whole bunch of money. And
How old were you at that point?
I was young when I graduated. I was probably 21. So yeah, 21 maybe. And then let's see. And then I went to Southeast Asia for maybe 2 years.
So, what was it like being in the high Arctic? What were you doing there?
I was a driller, and then my boss ended up having to go back to Ottawa, so I became the head driller in this island. We were experimenting with 4 different drills, and the one I was working on was the one that worked. But honestly, just slugging it out every day, and was super lucrative. So my McGill loans were $6,000 at the time, which Americans laugh at, and I had another $8,000 left over, which paid for I don't know, almost 2 years in Southeast Asia. So I just did the Asian Trail thing. So I lived in Kathmandu and did lots of hiking in Everest and Annapurna and
Um,
I don't know, lived in the desert in Jaisalmer. And then I ended up working for Mother Teresa in Calcutta. So that was probably the first time I went, oh, maybe I'll
wow.
be a doctor. So I had certainly had not thought of that before.
Just to briefly double click on that, like what was that like? Just meeting her and that experience.
Oh, well, she was sort of shorter than me when I was sitting down, and she had a big handshake, and we had some hilarious conversations. And her thing really worked. It was a little bit strange there, but I was working in the leprosarium. Most of the males worked there where the lepers were. And I wasn't a doctor or anything. So I was just literally feeding people and keeping them clean and engaging. It was a good lesson, Puneet, in that health is relative because I had this one guy with no nose, no ears, all his limbs gone. And he looked at my freckles and he said, is that curable? Yeah. And he
Yeah.
just had to see too much of that. So I said, actually, in my country, it's a sign of great beauty. And he sort of withdrew a bit. But and then this might be kind of interesting for later. Then I came back and applied to med school to McMaster, the only place that would take me. And then I didn't get in. And then I started a company in the interim, a kind of environmental consulting company that sort of took off. Ended up selling it to some people from the INSEAD. And when I got into med school the second year, and yeah.
What did that company do?
Oh, it was environmental consulting. So it was kind of the first wave. This is the early 80s or mid 80s of the first green wave. And so we would go into big corporations. So we did Amex and all sorts of stuff. Our real clients were like the Ministry of whatever, and they were sort of mandated to do it. And we would just completely renovate their whole process. So it sounds silly now, but we'd put them on. We'd have recycled paper business cards and change their lights and change their coffee machine and sort of a one-stop shop for all that stuff. Yeah.
To be doing that in the 80s is pretty pioneering.
Yeah. It was fun. We got it right up in the Financial Post. And yeah. So then I loved it, actually. I got into medicine and I said, oh, I'm not going to do medicine. I really love running this business. But I don't know, McMaster just really appealed to me, the different people going there. And so I ended up cashing out and started med school.
So you did eventually get into Mac then, like you applied again?
The second time, yeah.
Wow. Well, they're a smart move on their part. And, absolutely, McMaster does have a habit of catering to, obviously, people taking kind of a different path, people coming from kind of diverse backgrounds. I'm a Mac alumni as well. And my business partner, Damon Ramsey, we started the Input Health, the electronic medical record company. We also went to Mac. So it's not unexpected that all these stories are kind of connecting back to that university.
I always find that so interesting. Just like I think about me doing an English lit degree and running a business and then just practicing primary care medicine for 20 or 25 years and then going back to becoming a scriptwriter for YouTube and launching a whole bunch of little companies. So
not unexpected, right?
Yeah.
But so at that point, McMaster, because obviously McMaster has a history, and for those listeners who aren't familiar, McMaster is a university just outside of Toronto. I believe it started in the 50s or 60s, if I'm not mistaken.
Yeah.
And a kind of a storied tradition of kind of unorthodox approaches, typically non-didactic approaches to teaching. So a lot of small group based, problem-based learning. In fact, I believe even the concept of problem-based learning is, in medicine at least, kind of has its roots in McMaster, along with the term evidence-based medicine. But in the 80s, what was the program? Because I'm sure the program was quite different from what it was when I was there in 2006 to 2009.
Yeah, we were probably middle of the, like, you probably were sort of more like normal med schools. I think when I was started, it was much more crazy. It's a good example of like a 35-year-old guy. His name was John Evans, so everybody thought he was my dad. So I tell him that it used to grease my pathway there. But and I was in school with one of his kids. But and I would say, so I don't know what it was for you, but 100 people got in. I would say maybe 75 or 80% were still pretty traditional, smart biochem majors or whatever. Maybe 15% were like nurses, nurse practitioners, pharmacists. And I felt like they were the superstars of our school, to be honest. They were just ahead of people like me for sure. And then 5% of us were, English lit major, French major, Toronto Symphony Orchestra, rabbi. We had some really interesting people, but it was such a wonderful place to learn. And the professors were so, it was definitely much less stiff than when I came to U of T and more traditional teaching kind of thing. So yeah, it was a blessing.
Yeah. Very cool. And then, so what happened after? So, you went through medical training. Did you know that family medicine was sort of the end goal, or how did you end up in primary care and family medicine?
Yeah. I mean, this comes and goes, but at times, family medicine's the top of the thing. And at other times, seems like now it's at the bottom of the barrel in choices. And yeah, I was not really great at any one thing. So family medicine seemed appealing. I had that experience that a lot of medical students do, where we kind of worship the specialist in the big hospital and they're so good at what they do. And then I go out and do like a rural family medicine thing, and the person's like running the emerge, delivering babies, incredible range and knowledge. And you're just like, wow, this guy's doing, or this woman's doing way more than the people I've been doing in these very small practices. And I was blown away by that a bit. But honestly, I think I'm just a generalist at heart. And so it just felt right.
Absolutely. And I had a very similar experience. I was never exposed to rural medicine until I was into my residency, and I never thought it was something I would even entertain. I went there and I had the same experience. I was in Dunnville, Ontario, and I worked with an Irish doctor there who's just a fantastic human being, incredible clinician. And again, it's just everything from bloodletting to admitting the patient, or taking the patient upstairs to get IV fluid, to having the patient come back into the emergency department, to taking them to imaging. It was just like a complete spectrum of care. And I think it's the role that you play in people's lives and the extent to which you can understand the human experience and condition is very unique in especially that type of primary care, which, unfortunately, it's not the type that we most often see in urban settings, at least right now.
Yeah. I would say we're going to talk about Apple a bit, but it took a little while for Apple to get it, but they actually get it that all these major diseases all have this continuum of care. And I'm actually better at taking care of, front end depression and anxiety than maybe the psychiatrist is, who's just seeing hospitalized patients and treatment resistant patients. Because I have an advantage because I can intertwine it with the rest of their lives and with all the other health stuff that they've got going on, and a longer term relationship, and just some of the skills you acquire as a primary care clinician. But so often at Apple, I'd sort of manage all these little mini startups we were doing as the doctor, and then at one point we might reach out to the superstars in the field, and but it was interesting watching that continuum of care and watching them kind of figure that out, that there's a whole story here in all these diseases, and how to manage them most successfully. So yeah
100%. So what was your career like going through family medicine? You were at the University of Toronto. I understand you were practicing in Toronto for the bulk of that, or really the majority of your clinical career. How did your work in knowledge translation, content creation emerge, and what was your career in family medicine like?
Yeah, I think just because, as you said earlier, I came out of Mac. I did a year with Sackett. in ClinEpi, and I was just kind of a critical appraisal guy. I was probably above average, maybe. And then I really got into it. So I started the critical appraisal series in our national journal, the CFP. And then I chaired the provincial guideline groups, and I, was a scientific officer for knowledge translation for the CIHR and all these kind of, I even wrote chief edited a textbook of medicine. I don't know if you ever used the primary care source book thing. So so I kind of just traditional, trying to support best practice in primary care and what's the best way to do something. And then, I don't know, Puneet, maybe 2007, 2008, I kind of gave up on doctors and pivoted to the public, and got super interested in supporting kind of direct to consumer knowledge. And I just felt like that drove a lot of things in a more powerful way. And so I started a health media lab. That was just such an incredible experience. I just we had this program, which probably wouldn't be called this these days, but it's called Pimp My Clinic. And we'd go into clinics and we would you want a documentary film of the kind of sticky moments and hemophilia or whatever your disease was. Okay, we can do that. You want a Facebook fan page, you want an app, you want a whiteboard, you want a low literacy comic book that explains your illness. And they would just sort of pick from this menu. And the best part was all these creatives were working for me, and almost all of them, I was just their side hustle. It was just a thing that they loved doing, that was good for the world, that they made money at. And so that was really interesting. And then I watched one of those RSAs. So RSA was the first group to build the whiteboard. And I'm like, oh my God, this is great. And so in a weekend in Vancouver, I wrote the script for 23 and a half hours. We had this great illustrator called Lisa Sorza, and she did our comic books. And then I had a friend, Nick DePonce, who's sort of a famous documentary filmmaker, and he's sort of a MacGyver, I guess, of film. And so he figured out, and we rented a studio, and he put his big camera on a train track, and we just filmed Lisa and then edited it up, and we put out this whiteboard, and I was bragging to my kids that it had 250 views. And then I think on the Friday, it went to 19,000 views. And as you say, it was on Orange is the New Black, the Netflix series, and just kind of blew up. And then we built a whole kind of service that way. And at the same time, I was running a med school for the public. I started at the University of Toronto, and that was super interesting as well. Yeah.
I might get some more details around that experience of that first video. So the first video was the 23 and a half hours, which I believe is probably the most viewed one, and certainly the one that's most famous. And in this particular video, you obviously talk about kind of the importance of physical activity as being this kind of cornerstone thing that you can do as a health intervention. Is it safe to say that you did not anticipate this video to gain the traction that it did? Like, where did you anticipate it going, and what do you think was about it that made it go in a different direction?
Yeah, so definitely did not expect, and we were just in that kind of creative. I describe it to a lot of the people I work with as just placing 15 bets and doubling down on 2 or 3 of them. That's been a big approach of mine. And as far as what worked on it, I've been invited to so many conferences to speak about having a viral video. And I don't know, Puneet, if I had to boil it down to 2 things, one is the authenticity. I feel like, and I think that's even true today on TikTok and Insta Reels, the ones that really kind of blow up feel authentic, like this feels real. And I'm sure I can be tricked, but it just feels real. And I think the way we came at it was not, hey, you've got to do exercise. We came at it from, hey, what's the best thing for your health? Is it lowering your cholesterol? Is it cancer screening? Is it stopping smoking? Well, all those things are important and great. But when I look at the thing that kind of works for everything, so we're coming at it from the user POV. And I think the final thing was the Heath brothers, who are kind of business gurus, did a show on this where they felt like what they call shrunk the change. So instead of saying you have to exercise, half hour, an hour a day, I said, hey, can you limit your sitting and sleeping to 23 and a half hours a day? And people are like, oh, okay, I can do that. So there's a little bit of a nudge there. And I think it's just acknowledging that it's not easy for everybody. And I'm not asking people to do triathlons or whatever. I'm just asking people to kind of walk and just kind of build it into your day. So I think that, and then there's obviously something about the whiteboard that's super engaging. You've got the audio, you've got the visual. We do a lot of storification of science. So on that one, we might have said, people walking to work in Tokyo, when they looked at their walk, if it was 20 minutes longer, they dropped their blood pressure this much more. So we just take trials and we try and storify them in neat ways. So it's all the usual ingredients, but we were just early to it.
Yeah, and it's sage advice even today, and I think it's something that we struggle with even today, which is being able to promote the need for activity and to find places where it can fit into people's ever busy and consumed lives. And a couple of questions around that. So first of all, do you think healthcare, and by healthcare, I guess I'll refer to the traditional healthcare system, has gotten any better at knowledge translation and at communicating and reaching the masses? Or do you feel like that breakthrough hasn't really happened and we're sort of back to the mean?
I'd probably segue into just health education right now. I think health education, Puneet, is having a moment right now. I think to kind of answer your question, in COVID, I feel like big medicine, so CDC, WebMD, whatever, hospitals failed. I think comms failed. As somebody said, in science, like vaccine science, we got an A. In social science, we got a D, understanding determinants of health and communicating to
people. It's a great way to put it. Yeah.
It didn't go well. I think there's other things happening. We had the rise of the health influencers. So Fauci's trumping the CDC, which also can be, you saw the politicization and the people are in their little echo boxes and they're just hearing from the people that aren't outside of their world. And so super interesting. You have just misinformation, that people are trying to misinform because it's super lucrative. And there's a mechanic in social where it's like, hey, all these people are controlling the dialogue and I'm pushing against that and I know the real truth and here's what it is. And then I think you have generative AI right now is, the answers they're giving is trumping WebMD and what we've done before. And that's super interesting. And then you just have the digitalization of healthcare. So I ran an email clinic, 2014 or something like that. Cause I had an 85-year-old woman come into my clinic and say, Mike, my husband's got Alzheimer's. I can't come into your clinic. Can you email me? So we just started up this email clinic. I didn't get paid for it. But, in COVID, that went from 1% of practice to 70 or 80% of practice. And now it's back down to 20%, but we would never have got to 20% if it hadn't been for COVID. And so I think there's a big opportunity around health education in that world. So I would create these sort of playlists that my secretary, this is so old school, but would, and I didn't want the email to come from me. So it would come from my clinic and I'd say, oh, I built a little playlist on back pain or losing weight or high blood pressure. On your way out, just check the box and my front desk staff will send you my little playlist, which was me being a little bit of a kind of benign dictator saying, here's what you should do. And here's great resources to, here's a decision aid on a cholesterol statin or something like that. And then, by the way, instead of just clicking the thing they had, the high cholesterol, they would click anxiety and they wanted to get it all kind of thing. And I was like, oh, that's so interesting. They want these things sent to them, especially from me because I'm, their caregiver and they trust me, hopefully. So I think to answer your question, is big medicine doing it? I think no. And I think health influencers, some of them are great. You and I started following smart infectious disease people who are like, gosh, I don't know. Here's the data. Here's my best guess. We're like, great. But now you have your trainer telling you which apolipoprotein B to do. And you can't eat sugar
Yeah.
for the rest of your life and whatever it is. So it's a tricky time, but I also think that creates an
Yeah.
opportunity.
For sure. It's a double-edged sword because, you can certainly make the argument that people who are health influencers, and obviously there's a whole spectrum of people who are health influencers, ranging from those that are evidence grounded to those that are a bit more marketing focused. Perhaps that's the politically correct way to put it. But the double-edged sword is really that on one hand, I feel like they are fundamentally getting people to think and act more about their health. You could argue that they're perhaps taking advantage of that in some cases. But then the other side is just the sheer volume of content and of influencers and people saying the same thing in slightly different ways, and in many cases kind of obfuscating the truth as a result of that is I think the concerning part, because I think as an individual person in society, it's overwhelming to know, okay, here's, and it was funny, I was just I'm going to be traveling to Japan soon, and I was trying to read up slash see what people are saying regarding jet lag, and it's just overwhelming, that the tidal wave of knowledge that comes at you. Whereas, to your point, being able to speak to generative AI, whether it's kind of talking to, Meta AI or talking to GPT 4.0 now, it gives you a clear and succinct answer, and you can ask it to reference that, and then you can do your due diligence, and it just feels so much lighter as an experience. So
Yeah.
I do agree with you. I think there's going to be an entire area that I think is explored around the simplification of the interface between the human and knowledge. And it may very well be that generative AI ends up representing that. Obviously, much remains on speculation right now, but that's certainly the direction that I'm sensing things are going in.
Yeah. Can I say three things about that? So first about
Yeah.
the tidal wave, like there's a lovely study done by some UBC psychiatrists. I don't know if you saw this, but it was looking at ADHD on TikTok. And they looked
Mm-hmm.
at these videos, and on average, each video had 2.8 million views. It was shared an average of 31,000 times. So like way more than, whatever hospital or
Mm-hmm.
whatever is doing. And then they kind of looked at it for the quality, and 52% of it was completely misleading. So bad advice. So if the viewer followed that advice, they would be behind where they were. And probably about 1 in 5 of the advice were actually sort of based in evidence and useful. So the other 80% not. And 49 of the 52 people posting were non-caregivers. So like
Mm-hmm.
non-healthcare professionals. So it's just a perfect example of, and a lot of those people are probably trying to do right and a little peer-to-peer healthcare, but it's tricky. And it's, as you say, it's a double-edged sword. The second thing is around this generative AI. Like, so let's say, Puneet, you said, hey, I'm fatigued into ChatGPT 4. Now,
Mm-hmm.
pretty easily, it can look at your wellness data in your phone. So it'll give you a great answer from the web. It'll pull it down. It'll probably personalize it a bit to you. So it feels a bit real. It could
Mm-hmm.
be wrong, by the way, but it feels pretty good. Then it'll look at, say, oh, Puneet, here's your sleep data and here's your exercise data. And your sleep data looks pretty good. Your exercise, though, is pretty crappy. And we know, and maybe you didn't
Mm-hmm.
know this, that exercise counterintuitively the number one treatment for fatigue. And so, maybe you could do that. And then Puneet says, oh, yeah, you can look at my health data on my phone, which is bigger in the States here because people are going to so many different healthcare providers. And so once
Mm-hmm.
Puneet checks that box and the ChatGPT 4 can look at his health data, it'll also say, oh, by the way, Puneet, it looks like you're on a thyroid medication for low thyroid that you haven't had checked in 2 years. So it might be a good idea to do that
Mm-hmm.
too. So compare your, Insta TikTok answer to your WebMD answer to that kind of answer. Now you're cooking with gas a bit. Super, super interesting with some of the fears of AI baked into that, if you know what I mean. So,
100%.
letting it look at your data. So it's very interesting. Yeah.
Yeah, and maybe this is a good opportunity to segue a little bit into talking about your work at Apple. So I understand you've been there now for more than half a decade, if I'm not mistaken, perhaps even a little bit longer. What were you doing there, and at least to the extent that you can share, and what was it like working at Apple as a physician?
Yeah, so I was there for almost 8 years, I guess, and I just retired from there to do a whole bunch of other stuff. But Punita was just so incredible. As you're implying, Apple is very secretive, so I can't talk about all the little details, but just suffice to say
Of
that
course.
what you see on your phone and watch now, which is still a bit of a dog's breakfast, I would say, in the health app and stuff, is really just the tip of the iceberg. There's a zillion trials going mostly on the spectrum of, hey, can we actually, tell if somebody's depressed or mild cognitively impaired or has a pneumonia or whatever it is, and doing big trials on that. And if we can, a lot of times we can't, but if we can, let's build a great experience around that. And that was such a interesting thing. But I would say three things about Apple. One is it's just an incredible place, like so much talent. Puneet, you're in this building, like Apple Park has a 35-acre forest in the middle. Like the first time I went to Apple Park wasn't open yet. I was at their thing and like Stevie Wonder's playing in the little
My gosh.
pit there, and there's like 100 people sitting around drinking beer.
Yeah.
So much into
This is one infinite loop, right?
yeah, one infinite loop, yeah, and
Yeah.
they don't allow people into Apple Park really. I mean, you can get in there. I think I brought your friend Damon in there once, but it's trickier. But when people get in there, it's going to be the 10th wonder of the world. I think, and I think in academia and medicine, we think we kind of own brain power, but it's the brain power there is shocking, and it's kind of typical brain power and atypical brain power. I just learned so much, and they're really interested in science and evidence, which, and I don't know why that surprised me, but it surprised me a bit. Two, I would say, is the scale. I think most of the physicians that you interview on this or that are listening to this, are thinking that, hey, I'm the touchstone for my patients. I'm the family doc. I'm their connection to health. And I agree with that. That's true. That's certainly how I felt. But they're looking at their phone 85 times a day, every day. So your patient might come and see you 2 or 3 times a year, but I'm seeing them 85 times a day on the phone. And health is a lot about what you do every day, not what you do the week before you see the doctor. So that's super interesting to me. And we're not talking about like 80,000 people in a massive family practice or, even 1 million people. We're talking 1 billion people. So the scale of things when we'd run these experiments on Siri or whatever were insane. And then the last thing is just everybody takes your call, or if you reach out. So, the White House is calling, or we're doing the whole government of Singapore, or just some super smart cough detection app that's built in some small town in Germany or Israel or something. It's just, they just come and do their pitch, and that was such a luxury for me as a kind of lifelong learner, doctor type. So,
yeah. I can appreciate that. And I think that scale is something hard for any human being to really wrap their head around. And you're absolutely right. When you think about what we're trying to accomplish in primary care and preventative medicine and public health, the opportunity to be able to pull the strings and to be able to influence things, bend the arc towards a positive health outcome at that scale is just such a fantastic opportunity. So I can only appreciate how incredible that must have felt for yourself. And, and to a much, much lesser extent, I remember that feeling going from, having, running a startup, being an entrepreneur and being a physician, how hard it was to be able to get conversations. Then we were acquired by a much larger entity. In this case, it was TELUS Health, which, in the Canadian digital health landscape, it's a name. And it changed the way conversations took place immediately, because all of a sudden, you have access to an X number of clients and access to, a certain amount of capital. And I can only imagine exponentially greater kind of being at the top of the pyramid there at Apple. So
yeah, same.
Yeah. So a question around that. Now that you've spent, 8 years working kind of deep in and big tech, do you feel like it's left you more optimistic about the ability for big tech to have a positive impact on health? And and not specifically, picking on Apple in any way about this, but just in general.
Yeah, I mean, I think big tech is a much bigger conversation. What I like about Apple is the belief in science and the privacy thing. We've really kind of locked down on that. I think, I mean, the lessons I learned there are first, probably like you had to tell us, like just a whole different thinking about users and designing experiences. Apple's obviously best in the world at that. So it's just so incredible that to use as a paradigm for the rest of us as we struggle. Now, we don't have the resources of Apple, but just having that feeling where the user experience is so easy and comfortable, and it was great. It also makes it very hard. Like I just finished a massive trial, showed a big difference in asthma outcomes. I'm like, oh, we got to get this on the health app today. And the reality is that there's a whole bunch of other things under this tent pole that might be better than what I'm talking about, or might be worse, but they have to make it perfect, and they have to make it in 80 languages, and they have to whatever. So it's not good. It's going to be another 5 years before you're going to see that on the health app, maybe sooner. But so that was a bit frustrating. The secrecy at Apple is a mixed bag. I get it from their perspective, but I never really got it. I'm a person that loves learning from other people and failures and stuff. And I don't think the outside world really gets it. Like even within Apple, I can't share what I'm doing with another health team. So it is like super locked down and secretive what you're doing. And so I wasn't doing any talks, which I miss. I miss going to some place and somebody smarter than me about whatever and all that learning. So in that way, not as great. Apple, generative AI is a perfect example. They're not as publicly ahead as, Microsoft or Google, who are running all these great experiments, and, you can actually feel it. Apple's sort of like, hey, we're going to do it, but we're going to do it right. And, and also very focused. So, we're dropping other projects just to work on this. And, that's their way.
I think Apple Car was famously one of the projects that was sidelined.
Yeah. So it was, and people are like, oh, why'd they do that? But in a way, I love that about Apple, because it's like, hey, of course we could build a car. And of course, most of cars now are a software experience, and we're really good at that. But somebody at one point said, are we really going to bring much more than you are with your Tesla or whatever you're running now on your iPhone anyways? And our share price would go way up and all these things, but we're not going to make a big difference here, and we can do better in other things. So somebody said, okay, we put $1 zillion into this, but we're shutting it down. And to me, that's a good thing in a company that they're able to do that. So the other main lesson around tech is just the incremental nature of it. If you look at so much of tech right now, it's not doing that well. There's lots of negative parts of it. Their outcomes aren't great. But these guys, the startups maybe less so, but these big players are playing the long game here. And they're just like, okay, increment. And I don't think some people in healthcare kind of see that, this isn't a one-time thing. We're trying to build this all the time. And that's the thing you get at Apple. So if you and I, Praneet, were building a AFib detection thing, we would build the technology, and then we'd have to go get money, and then we'd improve our algorithm, and then we'd run a big trial, and then we'd have to go get more money. And Apple's doing all that at the same time. They're tweaking their algorithm every day. They're gathering the information. They're running the research trial. And so there's a power they have for doing these things. And then the last thing is they found health really hard, and they need the last unit I was on for the last 3 or 4 years was all about partnership, because they realized they couldn't do it alone. It's not something that somebody can figure out in the back of a room. It's just too hard. And so I think there's a lot of growing pains for big tech that way. It's not something they can do the little things, but to actually change healthcare systems. And we've seen so many failures of big companies trying to do it.
Yeah.
So
Absolutely. And most recently, Walmart Health kind of closing their doors. And it's just literally, it's been every few months you hear about a project that I think people were really hopeful that if someone can do it, it's going to be Amazon. If someone can do it, it's going to be Walmart, in terms of just being able to appropriately commoditize certain pieces of healthcare, and they just end up pulling back. And I think it speaks to just how messy and fragmented and all the mushy stuff that comes with interpersonal relationships and varied experiences and cultural factors and the legalities of information. And yeah, it's a mess for organizations that are looking for scale and not just kind of saying, here's a little bit of a margin. They have other easier ways to create more margins.
Yeah.
Why would
Yeah.
why would they mess with that? But going back to the Apple question, actually, one of the things I've been really interested to hear about is, Apple, of course, has a great presence in hardware, particularly hardware relating to wearables, whether it's AirPods or Apple Watch, other devices. Where do you see Apple's wearable devices intersecting with health? Where's that going?
I think the one thing I'd say about wearables, Paneet, is everybody's always asking me, should I buy a Whoop or a Ring or whatever? And some of them have, like, Oura Ring has a really nice experience around sleep that's more coaching than the Apple one. Other ones give you more data. I actually feel like that's not the right question. The right question is, at least in my mind, is you. And I feel like there's like 3 or 4 big categories here. So there's people who just don't want to know. I know how much I'm sleeping. I know I don't need to get my steps tracked or whatever. I'm fine. And all these people, by the way, are totally right. The second group, which is probably the biggest group, is just like, I just want a small dashboard. Like, give me like 4 or 5 things. Explain to me cardiorespiratory fitness or my sleep or whatever. And I just want a great experience around 3 or 4 things. And that's it. I don't need to see, I'm not running big experiments or whatever. And then you have the quantified selfers.
The quants.
They're great. And they're running experiments and all that kind of stuff. But they're also at risk for kind of over-indexing, I would say. Like, sleep's a great example. So they're waking up. This is kind of why we sort of just kept it simple with sleep, is we, they look and they, I didn't have good REM sleep. I'm going to have a bad day. And I just don't like that. There's a lovely trial at Oxford. They took about 70 patients. So let's say there was 100 patients and it was 100 Paneets and they all slept 6.1 hours a night. So they were all insomnia, low sleep. 50 got, hey, you're not sleeping enough. You need to improve your game, blah, blah, blah. The other 50 got, hey, that's great. 6.1 hours. Way to go. And the ones who got the great feedback actually had less fatigue, better productivity, and whatever. So we actually have an impact on people when we give this positive or negative feedback. And I do think there's also a smaller group that this feedback just gives them major anxiety. Like, they don't want to know, like, it's just too much. And so I think that's a big question, is asking yourself. What I would say that's great about wearables is there's health data, your data, and then there's health education. And they're both fine in themselves. But when you can bring those together, then you're cooking with gas. So if I tell Paneet, hey, if you drink an extra 2 glasses of wine tonight, your sleep architecture is not going to be great. But if you see it yourself and you're like, oh gosh, when I have that extra 2 glasses of wine and I look at my sleep data, that's a whole different kettle of fish. And so it's combining personal data with really great education. I think that's the future of wearables. I think you and I, as family docs, will be prescribing apps for every chronic disease in the future. They'll get a dashboard, a version will be sent to the clinician. There'll be teachable moments looking at, things you can do. Education will be customized. And so I think for those things, even if you're a low wearable person, you're going to be using those. So I hope you would, or it's a good enough experience that you feel like it's good.
Yeah.
Maybe not everybody, but most. Yeah.
Yeah. I mean, I think intuitively it makes a lot of sense to think about the fact that, going to your point around people who are really deeply quantifying their health and their health experience, I think just setting up neural pathways where you're responding positively or negatively to data, even at the micro level, is it probably builds towards anxiety, if not anything else. So I can totally understand why that Oxford study showed that just a positive expectation of the
Yeah.
day impacts how your day is versus, perseverating over some number that's come up on a device, which,
Uh,
even if it is accurate, you get a negative outcome from that. So that I think that intuitively makes sense. And I guess to build on what you said, and maybe you can share this, maybe you can't, but do you see Apple producing clinical grade apps for things like diabetes dashboards or hypertension or things like that? Or do you see that happening more outside of Apple, but within the iOS ecosystem?
Honestly, Puneet, that's a big question even within Apple, and different people have different views. I suspect it'll be a little bit like President's Choice at Loblaws. They start selling something, it flies off the shelf, and then they create a President's Choice version that's cheaper and better. So I think they will make medical grade at one point, and but they're definitely scared of that in a way now. But your ECG is there. I was there the first time we saw the one lead ECG in the AFib, and it's just incredible. And so I think that's really interesting. But all these things, when people look at testing, they think they're black and white, and there's a false positive rate and a false negative rate, and challenges to all of them. So that's something Apple has to figure out. And I do feel like they could do a better job on the communication. We talk about the what, so what, now what, and I think they're good at the what, but they need to get better at the so what, now what.
So for people who are building healthcare companies, who are entrepreneurs in the digital health space, is it safe to say that Apple is still in the market of M&A activity in terms of acquiring digital health companies? Do you have any words of advice for people who are building digital health apps?
Yeah, for sure. So one is it's hard to get in the door because literally every company is better. Oh, if only we were on the native iOS platform, we would be so much better. You're like, yeah, so would everybody. Two is for a lot of smaller companies, it's much more acqui-hire. That's what I was. So for people who don't understand that, they don't buy the company, but let's say Puneet and his three friends develop a great cough detection app. They basically give Puneet and his two buddies a great job, and they value the company and pay them, but it's all as employees of and they get a whole bunch of RSUs at the beginning that pay off over time because they want you to stay. So they're really wanting to hire your brain power, because anything you can do, they can do better. And having said that, they don't have the drive that you have of just, you're a pulmonologist, you want to create this great cough detection app, or you're a psychiatrist and you've got this great thought challenger. You don't have to be, and in fact, Apple has a history of not buying big companies. People thought they should have bought Netflix or Tesla or whatever in early days. So, but they're doing young companies, and we take the whole teams, and it's super interesting that way. There's a whole hardware conversation probably. There's different health units at Apple, that are looking at hardware and the native app experience and partnerships and all these kind of things. So hardware is another, how unique is what you're bringing to the game hardware wise is super interesting. But when people came in and just said, here's what we're trying to do, here's our success so far, here's where we failed, and here's why we think if we joined Apple, it would be so much better. We just can't get to this point because we're underfunded or we're underpowered or we don't have the integrated possibilities. So, and that's it. And then they're very good at picking up on these. And it's a lot about the talent of the people. As Steve Jobs said, he's much more interested in the people than anything else. So I would frame it that way, as opposed to you've got this great business that Apple needs to have.
Gotcha. That's an interesting takeaway. So that being said, why do you think startups right now, particularly startups in healthcare, struggle in trying to tackle preventative health? And why are we still so bad at preventative health today? What are your thoughts about that?
I do think it can be solved. The problem with preventive health, Puneet, is that almost like if you take the 5 big things, so you take activity, social connectedness, sleep, eating, and thinking style, how you think. It's hard to sleep when you've got Netflix. It's hard to have a to thought challenge when you're doom scrolling. It's hard to have people get very isolated in today's world very quickly, especially men as they get older. So in our Singapore data, they were dying 3 years younger with the loneliness. Eating, that's sort of the most obvious example. There's such a plentiful, fast, and easy and delicious food. So the nudges in the rest of our world, and then activity, we're on the escalator and everything, so we don't have to make our day harder. So it's a lot to kind of battle back against these big kind of structural things. And this is a good example in a public thing. So at Apple, we use a lot of behavioral economics. So for instance, we would go to an insurance company, say, here's 1,000 free watches. You give it to your people. And then every month we'll hit them with a little health behavior we want them to do. Pretty small, like this week, we want you to add 1,000 steps. We want you to go, flu shot's probably a bigger thing, but we want you to fill out this HAM-D depression score. We want you to whatever. And if they did that activity, they would get to keep the watch for free. And we're talking like $10 a month or whatever. But we kind of took advantage of that kind of bias of not wanting to, what we call loss aversion. Now you've got the watch, you don't want to lose it. It's much more valuable to you. And so you're like, okay, I'll do this little thing because I want to keep the watch. And so I think we have to build a system around that. In Singapore, we have a project called Lumi, again, very public. And we gamify that, and we actually reward Singaporeans with money. But it's a game. It's a little bit like Duolingo, and they get rewarded for these behaviors. And we had tons of success around wellness behaviors. We increased activity by 35%, and we're most effective in couch potatoes. So I think it's not telling people what to do. It's creating a choice architecture that's better and a nudge fest. And the nice thing about watches is to keep score a bit. There are some things we're not good at keeping score on, but we can keep score. And then I would say our most powerful nudge was social. So when you're sharing your results, you bring in competition, you bring in accountability, you bring in support, and different people need different combinations of that. So, yeah.
Yeah, you've mentioned Singapore a couple of times in terms of health collaborations. Is there like a strategic partnership there? Is there a reason why Singapore has been kind of an ideal partner in some of these projects?
Yeah. Again, they're a great lab, I guess. It's like 5 million people packed into like the size of Burlington, really, very small space. They're great data sharers. It's kind of one healthcare system. It's a bit tricky, but they do collect tons of data so you can see what you're doing. And then it's not like you're dealing with trying to do something in Timmins and something in Toronto. It's just one space. Yeah. And so your interventions are easier. There's tons of cohort data that we can compare to other things. And then the ministry is so invested in being a great healthcare system, and they're tech friendly. The challenges are, and the other thing is it's Indian, kind of Mandalay and Chinese. So you get a kind of nice overview of building things for Asia. That's kind of interesting. There's a tricky side to that, which is it's a different culture, so I don't know, mental health is interesting. They don't really talk about depression or anxiety so much. It's changing a bit, but it's more about productivity and stress and work stress. That's how they couch it, which would be different here, So it's different that way. But of course, Apple has things going all over the place. And but Singapore is a fun place for us to lab it out there. Yeah.
Yeah, you can almost see it as like a kind of a Framingham of sorts, just in terms of being able to create an environment to be able to do studies and select a population. We were thinking a little bit along those lines during the Input Health Days, and actually when we were at TELUS Health, we had a great opportunity to deploy the collaborative health record to all of PEI and through Health PEI, and very much of a similar idea. One jurisdiction, one province, limited geographic area, and it kind of makes for a better opportunity to be able to deploy, public health interventions or programs or use technology in a bit more of a concerted way. So I can probably draw some parallels there.
Yeah, yeah. As I said earlier, you can lay your 15 bets there and double down on the 3 or 4
Yeah.
that works for people in PI. And that might not work in Toronto or Vancouver, but
Yeah.
it's just a lot easier.
Yeah. So what do you see coming down the road in technology that excites you the most? Maybe something that people outside of Silicon Valley or outside of working in tech might not have privy to.
You mean companies that I like, or you mean just themes?
Maybe themes and technologies.
Yeah. I just love the ability to personalize and to make people feel like they're getting information that's really unique to them. So that's where some of the stuff around, combining data and health education, all that stuff, I think is so important. I think some of the coaching platforms are really interesting to me. I haven't seen somebody totally rock it. And we've seen quite a few things. So we see some companies come to us, they're doing the more low tech. They've got like people who worked at Walmart or Amazon, and they're just very good. And they're from that community, and they coach them up with behavioral scientists to do a great job of counseling the patients in the field. I kind of love that. And then I also love Lark and some of the bot stuff and how much it doesn't quite work for me, but I just feel like, wow, if it got going, that would be really interesting to me. Another thing is I like when companies go after these kind of hard to reach populations. So I like City Block Health. Do you know about them? Yeah.
Yeah, that was a spinoff out of Google, right? I think it was one of the.
Yeah. And they're investing in the community and neighborhood, and it's all about looking after kind of, I would guess, more vulnerable populations. I definitely do not have insight into their whole, like how it's truly going and their cost benefit and all that kind of stuff. But I think people outside of, well, I think most people think of tech as just for wealthier quantified selfers, or educated people. And that's kind of true, obviously. But we did a trial with asthma where we built them a nice little app, and this is about to be published, I think, in JAMA. They logged their triggers. So if it was pollen and Puneet lives in Toronto, we would scrape in the pollen data, and it would say, hey, Puneet, pollen rates have gone up 10%. You might want to take your puffer. Then I built like 10 whiteboards in there. So that could be customized and asthma has a big educational lift. As you know, people take the blue puffer because it makes them feel better, but they should be taking the steroid. They're fearful of steroids. They haven't home-proofed their house. And asthma is in a lot of ways a disease of low socioeconomics, 7% of the population. So it's not just that, but they have definitely a higher burden. And so they would get, and also with the watch, with heart rate and O2 sats, with heart rate, it's well known that we can predict respiratory infections and so on and so forth, which is the single biggest predictor of an asthma flare. So they get the education, they get the notifications, they're personalized. We made some difference with the kind of higher SES people. We were doing this with Anthem. But when we looked at Medicaid patients, which was 25% of our population, those guys were reducing emerge visits by 42%. So they were probably getting crappier care to begin with. But my point is that tech worked for them. Do I still think there's a big digital divide with seniors? 100%. Do I think Apple should be doing way more for seniors and UI? 100%. But to think that low health literacy patients can't benefit from tech, I think would be wrong. We built all our education with low literacy in mind, and they're smart and they're tech savvy in a lot of ways. And so City Block Health, starting with populations like that, I love. There's another one that you might know about, Moneta. Do you know about that? So they're looking at mild cognitive impairment. Yeah, Moneta. They're looking at mild cognitive impairment, and they're run by, tech people. They ended up like dropping their app and their website and they end up just calling them 3 times a week. But and they had a very human part of the intake. So they were assessed for, this is mostly because they would get paid for it in sort of neurological deserts where there's no kind of neuro help or no neurocognitive training. And then,
Mm-hmm.
but with a backbone LLM AI thing, they can actually build personalized neurocognitive training for those people, and they supply it over the phone. And it's a little bit like a Wordle effect. They were wanting to test themselves. So
Yeah.
they only had to do it 3 times a week, but they're doing it 4 times a week. And they just have pilot study, but they're having 90% were getting an increase in their cognition scores. So that kind of stuff is super interesting to me, like harder to treat populations, maybe coming at
Mm-hmm.
them with super low tech, but in the background, I feel like with AI, we went right to diagnosis and all these kind of sexy things. And I think we mostly failed. And I think some of these lower hanging fruit where it's more in the backbone rather than the front experience. So for me, that's an exciting thing that people don't usually think about with Silicon Valley is going after more vulnerable populations. And that's an opportunity.
Oh, that's fantastic. A couple of questions to ask before we wrap up, cognizant of time. What would you say healthcare providers and system leaders can be doing today to prep for tomorrow? If you were speaking to program directors at residency programs or medical schools, what would you be telling them?
My answer is biased as an English lit major who took off 5 years and then ran a media lab and all this kind of stuff. But if I had to, Penny, when I go to these things at medical schools now, I'm sort of struck by how much they're looking for solutions from within. It's just a whole bunch of doctors and nurses and whoever else in a room who are super smart, who know the population. Obviously it's great, but I feel like the solutions, it's like, at the very beginning of this conversation, we were talking about all of us doing organic chemistry to get into med school because that's what everybody did. So you're like, oh, that's what you need to do. But I've never used organic chemistry in my clinical interactions. And I'm sure if you ask the public, they want to know about, they want you to be a great communicator and a great librarian and a great and creative and have a high emotional intelligence. That's what we should be looking for in a doctor, not organic chemistry scores, but that's how we do it because that's how we've always done it. And I think that happens a lot in medicine. And if I was talking to those people, I would want them to get really good at engaging other fields like creatives, user designers, expert patients, tech, startup people, marketing, really good at sort of introducing these people into their solution finding. It's just based on my own thing that the transformative ideas I've benefited from and have won, but have been connected to my travels when I kind of come to the intersection of different disciplines. And I feel like we kind of try and own it too much. And Apple is the same problem, to be honest. And so I think we need to just be more, and when we think interdisciplinary medicine, we think of nurses and pharmacists or whatever. I think we need to think way outside that, which is what your and my career is kind of like. Yeah.
Absolutely. I mean, that resonates so much with me. And obviously that's part of kind of the MO of this podcast as well, which is to bring in people largely from the creative industry as well. So as you know, I've had science fiction authors, musicians, film directors, people you would otherwise never really talk to about health, but who happen to be really good at communicating the human experience. And I think there's something to be said about just bringing kind of the humanity back to the practice of medicine, and arguably at a time where technology is beginning to make its encroachments, it becomes that much more important to actually preserve and understand the human experience. And that doesn't necessarily come through organic chemistry, but
it's true. And I feel a bit for health right now. I mean, I think you just have to say the obvious of, all the walls are burning a little bit right now and they're just under horsepowered, and especially in primary care. And so this seems like a little bit of a luxury, but I still agree with the sentiment. And sometimes it's good when it's blowing up. That's the time when good things happen. So,
Yeah, and I think hope can emerge from that, and I think people have felt for too long that things just aren't capable of changing, and that can be disenfranchising, and it can make people feel like this is just a never-ending cycle of the same thing. So at least when we all acknowledge that the walls are burning a bit, there's a hope that we're going to be building something new. And I think it's so important that everyone is open minded and willing to participate in those conversations when the time comes.
Totally. Having said that, I'm a Toronto Maple Leaf fan, so a lifelong burden
That
of
doesn't change, right?
disappointment and instant hope for the next year. So I'm
Yeah.
maybe not a good N of one. So yeah.
Yeah, that heuristic doesn't work there, I guess. Maybe that's an exception. But so, just some closing remarks. What's next for you? Where are you headed?
Yeah, so I've doing a kind of health education startup and just building a whole bunch of unique content for that. Honestly, Paneep, a lot of failure. I build these things that are just TMI and it's just my nature. I just drill too deep on them, but really progressing. And I've got a band that I'm getting back together again, sort of thing.
Oh, that's what instrument do you play?
No, I mean that. I mean that figuratively, meaning
Oh,
my
figured. Okay.
my yeah. The band I had before Apple. So I've got all these great, smart people that I work with, and so we're reemerging a bit. I wish I played an instrument. Two is I'm doing a whiteboard on the science of what I call X3, but the science of retirement. And I'm a little bit that way. Like when I had my vasectomy, we made it into a TV show and a radio show and a Globe and Mail article. So when I go through these life things, I'm only 60, but I'm just sort of figuring out, where is all this going? So I'm doing a whiteboard on the science of that, which we can talk about at a future podcast. It's just fascinating stuff, and mostly what people think is going to happen is wrong. So it's good. And then I've got a whole bunch of projects in the work that range from series with YouTube, like a medical school for the public with YouTube, and some other things. So and then I'm trying to kind of fix that with just how I want to live my life, and spending time with my 3 kids are in their 20s and all over the place. And my wife just came back from Rwanda doing a Partners in Health thing. So we're just trying to figure out our future, whether we move back to Canada, whether we stay here, all that kind of stuff. So lots of balls in the air, but I'm just kind of letting it come to me. And I've been helping a lot of groups think about their problems, which has been really fun for me, and then trying to be a geriatric athlete as well. I was actually going to start a geriatric sports medicine clinic, a virtual sports medicine clinic at one point. So
that's actually a brilliant idea.
I know.
There's a growing market for that.
There's a growing market, and my health platform thing is sort of loosely targeting people over 50 falling apart, but which is basically everybody I know. So yeah, but I'm really sort of positioning as a gap year, and really focused on learning and kind of saying yes to things. And and we had another AI doctor thing that kind of got acqui-hired. So I've done that as well. So anyways, just screwing around.
Wow. Well, Mike, suffice to say, you're a huge inspiration. Thank you for doing everything that you're doing, because I think there's obviously a very important role to be played, being a primary care physician, being able to be at the table at conversations across so many different places. For somebody like myself, who's early, mid stages of my career, kind of thinking about my next venture, and also looking for people who are role models and inspirations, it's very easy for me to say that you're one of them. So thank you for that, and thank you for taking the time to come on the show.
Oh, my pleasure. Thanks for letting me blither on, and I really enjoyed it. Thank you.